Welcome, everybody. My guest today is a very, very old friend, very dear friend, uh,
Very
who's
old, very old.
very, very old in my, a very old friendship and very old people. Bessel van der Kolk, who most of you, I am sure, are very familiar with his name, um, author of numerous books. And and most importantly, The Body Keeps the Score, which has been on the New York Times um, bestseller list for 11 years. And and still, if you haven't read it, be sure to pick it up. But I would imagine most of you have read it. And Bessel is I think one of the two or three pioneers in the trauma field. And and I know pioneer makes us even sound older. But somebody had to found this field, and you were that person. And
See,
all
I don't feel that at all, actually. I feel like there's many people who have made this grow, and I think it's a very interconnected network of people with very different perspectives. And
right,
I happen to have lucky enough to have won an annual conference where we brought people together. But as you know, because you're also one of those people, there's many people in our field who are stars. And
oh, absolutely.
yeah,
But you blazed a trail at that.
yeah, but so did many other people who have been forgotten. It's very easy to get forgotten in this field, you know.
Um, and who are you thinking of that we've forgotten?
Oh, I'm thinking about Mary Harvey. I'm thinking about Frank Putnam. I'm thinking about Rick Kluft. I'm thinking about Francine Shapiro. I'm thinking about Peter Levine. I'm thinking about Pat Ogden. I'm thinking about, now there's so many people. Roger Pittman, Eric Shalev, Bob Pinus. There's so many people who have really worked so hard to make this come to life that
Absolutely.
certainly
Well,
not just,
yes, that is
yeah,
true. It takes it takes more than a village.
takes a world. Like,
It's a world. Absolutely. Absolutely. Uh, so I mean, you and I met before either of us were in the trauma field. And I still remember when you used to tell me you shouldn't be doing what you're doing. You should be down the hall with me. Uh,
right. Well, I didn't even say that. I said, no, you're too smart to do stupid psych-farm research. Yeah.
right, right. It's real. I know it's so funny when I think back that I was doing psychopharmacology research. I was going to be a neuropsychologist. Now I think, oh my God, that would have been so boring. I am so glad that I was inspired to specialize in trauma. And in those days we had no tools, right? Like really the back in those early days when you told me I was too smart to be doing what I was doing, we didn't have many tools. We were just trying to understand the phenomenon.
Well, and we're trying to figure out what helps people. And we're
Right,
still trying to figure out what helps people. We haven't come to a final conclusion yet, have we?
right, right. It's still a work in progress, but we've come so far because what I remember is that there was nothing to start with. There was nothing but talk therapy,
That's
right?
right. Yeah, yeah.
Right? The
And
talking skills.
analyzing and being empathic with people and um, and trying to figure out how your mind works and then giving people advice more or less. or we still
Problem solving.
initially that if you can talk about the trauma will disappear.
Right.
And
But I,
that really was a big realization that talking about it was not enough to really let it go. Huh? Yeah, yeah.
right, I remember, I call it the hydraulic theory of
Right,
psychotherapy. You get it up and out and it's gone, which
right.
of course is, is definitely not the case.
That's what Freud said, huh? And that's the origin of psychoanalysis. That if you can talk about it, and I have the quote from Freud, then if you can put it into words, you don't need to do anything because it can get integrated into your memory, and then you'll be free to go on with your life.
Right.
And
And
then research and to see if that was true, and turned out no, that wasn't true.
right. And see,
Yeah.
that's what I loved about you, because as a postdoctoral fellow, I had this idea that how could it possibly help people who had suffered to suffer all over again what they had already suffered. So so I was very dubious, but I kept my mouth shut because who was I? I was a lowly postdoc. And and what you did was to research it,
Well,
right? So that actually there was data.
and because we were on the research floor.
Yeah.
Ah, and I had Timothy Leary's old office there, actually. Like,
Wow. All full
and,
circle is that.
and so I've always had the idea, yeah, you can say things, people always do, but if you do it, you need to actually collect the facts. Uh,
Right.
yeah, that's really, and that hasn't left me yet. Although some things are really hard to research.
Absolutely.
Things that you so beautifully talk about all this complexity inside. Of course, it's very hard to capture that in simple tables and graphs and stuff
Yeah.
like that. Huh? Yeah, yeah,
It's very hard to research.
yeah.
I mean, it's very hard. It's very hard to research treatments that are not manualized.
That's right. And in some ways, you cannot really manualize treatments because so much is a function of resonance between our mirror neuron systems. And do I know what you're talking about? And if I don't know what you're talking about, I cannot really reflect back to you what happens. So these are very complicated issues. And there's this thing I come from medicine, and much of research comes from medicine, where you can objectify things, but we're really talking about very complex emotional attunement issues that are extremely difficult to actually manualize. Yeah.
Right. Right. Now, I'm having a little memory of the period when you used to say to audiences, the therapeutic relationship doesn't matter.
I don't think I ever said that.
Well,
No,
that's
no,
what people heard.
no, that's not what I don't think I ever said that. I remember Dan Siegel accusing me of that also. I said, no, but what the research shows is that the therapeutic relationship is not enough. And what the research
Oh,
shows
oh,
now is that the therapeutic relationship is only useful and in as far as it mediates people learning to regulate themselves.
right,
And so, and it's very much like being a parent. You can love your kids.
right.
Loving your kids won't make them into productive and independent people. You also need to teach them certain skills and teach them certain values and approaches and boundaries. And,
Right.
and so
I,
that the warmth of the relationship. And the other thing that I'd like to say is that the therapeutic relationship really is not a relationship. You and I have a relationship because when I'm in trouble, I can call you and vice versa. But when you're somebody's therapist, it's a one-way relationship. I
right.
call my patients up and say, "Hey, I'm really feeling crappy today. Will you come and talk to me?"
Right. Do you have any free time today to talk? Yes, so true, so true. Right. It's a promise of a relationship that actually
Uh,
can't be fulfilled.
and you can say, I'll be there for you as much as I can with the following parameters,
Right.
which is different from your relationship with your kids, let's say.
Absolutely. Absolutely. Right. Yeah. Yes. Yes. So that I think I think you were I actually agree that especially in trauma, the therapeutic relationship is very complicated because we're triggering,
Yeah,
right? It's I mean, we're as helpful as we can be, we're as
yeah,
empathic as we can be,
yeah.
but by definition, we are triggering.
Yeah, and one thing that how we trigger people is we're always talking about safety.
I
But
know,
with the traumatized person, safety is threatening.
right.
And letting
Right.
your guard down, it makes you vulnerable. And so even the promise of, oh, let me be here for you and always be sweet for you, it's like, ew, that gives me the creeps.
Right. Or our expectation that they should trust us.
Yeah, exactly.
Thing.
Yeah,
Yeah.
yeah. No, that's a tough one. The issue of trust is a really big issue. And actually, as therapists, we need to earn people's trust.
Right. Right.
You know,
Oh,
to some degree, as a patient, you have to earn our trust also.
right. And I tell people,
Yeah,
actually, you never have to trust me. We have to be able to work together,
yeah.
but you don't have to trust me. That's not a requirement.
Yeah,
Because
well, that's not true either, of course. Like,
well, I mean, being able to work
yeah,
together is going to
you need to trust people.
imply some degree of trust.
In any relationship, nothing is unconditional.
Right.
Uh,
That is true.
but-
I know. Tell that to many disappointed husbands and wives and partners.
no,
Oh,
who said it? Was it you or some other sage person said? Oh no, actually, Steve Westmoreland had a picture. Uh, in all relationships, after you're a baby, all relationships are conditional. Huh?
right.
Yeah.
Right. Absolutely. Absolutely. Well, we have definitely come a long way since the talking cure and supportive psychotherapy. I mean, I remember when I went to your trauma center as a supervisor, you said, "You're not EMDR trained? Every therapist should be EMDR trained." And, and so thanks to you, I got trained in EMDR. And then you started talking about the body. So so of course that meant getting trained in sensory motor psychotherapy. And and we evolved.
Yeah,
We had these tools.
we have. And with experience and the lessons that we have learned from our patients. But I always still have the feeling we have so much more to learn. Huh? And it's interesting because both you and I meet very young therapists, and they think that now that I have my degree, I know how to be a therapist.
Right.
When you
Or
and
I
I were growing up, the world said, "Don't trust anybody over 30." Remember that? And today, it says, don't trust anybody under 50 because you just don't know enough. So you've done this work for a long time to even begin to be any good in some ways. Huh?
yes. Yeah. But don't you think, I mean, therapists who are young, but they're learners,
Yeah.
right? That that is a whole different kettle of
And that's an interesting thing. That um, I'm thinking I was a ward attendant before I did my residency. And I bet that because you're young and enthusiastic and full with hope and don't have any cynicism yet. Um, your open-heartedness,
Right,
curiosity can make a huge amount of difference. And then,
right,
so we have students at the trauma center and say, "Oh, I'm only working with this patient for 2 months. It won't make any difference." I say, I meet patients all the time who say, "When I was 12 or 18, I met this person, and that person just made a huge difference for me. I don't know what happened to her, but that we still can make a very deep impact on people, even though we're still young and don't know very much."
right.
Yeah,
Absolutely.
yeah,
I still quote a a client who I saw in 1991 during my postdoctoral fellowship.
yeah,
And at the time she said, Janina, you have to understand, I am missing the synapse for self-care. And of course it turned out she was right.
yeah, yeah.
But we didn't know that then. We didn't have the
That's
research.
a good example. How that, so I live, don't have a synapse. So how do we help people to get a synapse for self-care? That's a gigantic challenge, isn't it?
Yeah, yeah, yeah.
Yeah,
It was for her, this goes back to the role of mindfulness in
yeah.
any type of treatment, because being mindful of lacking the synapse for self-care, um, she was actually more able to be kind to herself and to do things that helped her regulate.
So she was able to do mindfulness stuff. Because that was one thing that really kept me exploring things. I used to send quite a few of my patients to John Kabat-Zinn's MBSR program in Worcester, and they always flunked out
Right. Oh, absolutely.
because mindfulness was too overwhelming for them.
Right.
Yeah. Yeah.
And and the type of mindfulness that I think works in trauma treatment is not meditation.
Right.
It's the ability to observe.
Yeah. Yeah.
The-
Absolutely. And and that is where we come in also, as therapists, because we help people to observe. That is really much of what we do.
Oh,
It's what's that like? What's that feel like? Where do you notice that? Huh? Notice that.
right.
Notice that. No-
I feel like I say
Right,
no
right,
200 times a day.
right.
Right.
And that's where it starts, to observe yourself. And that is quite a job for everybody. Yeah,
Right. And that's everyday mindfulness.
yeah,
And I always think of Thich Nhat Hanh as
yeah.
sort of the the um the person who talked about everyday mindfulness, the ability to notice moment by moment while while going about your business. And and I really think of of that kind of mindfulness, right? That stimulation of the medial prefrontal cortex
Yeah,
as as being essential for good psychotherapy. That
absolutely. Foundational. Yeah.
yeah, yeah,
And that's where we start. And that, as you and I know, may take quite a long time. I mean, the insurance company gives you 8 sessions. That's crazy.
well, thank God. I mean, I have to say, I'm so glad I don't, I don't take insurance. I haven't taken insurance in many years because in California, uh, insurance doesn't pay enough to make it worthwhile.
Yeah. And that's, of course, a huge issue in our profession. And that you and I are in position that we don't have to do that. But it also makes our services inaccessible to
Right,
many people who need it most. And and that it also makes therapists listen to what the insurance companies will tell them to do rather than what their clinical wisdom tells them what to do. And so it's a huge issue in our field, that we get getting prescribed what we can and cannot do, even though what gets prescribed is oftentimes not what people need.
Right. Well, but ironically, it's worst in the UK. They have their National Health Service has the fewest number of sessions. Their the Canadian Health Service gives more sessions. I think it's 20. Australia is in between. Um, but actually, in those countries, what the number of sessions is really much more stringently limited. Do you really think any therapist believes what the insurance companies say?
Now, see, I think this gets us maybe not where you want to go, but I think we are a very warped profession actually. Huh? We use a diagnostic system that is a foolish diagnostic system. It's embarrassing. And so we could pose codes on people's charts that are fundamentally meaningless.
Right.
And as long as we do that, we don't deserve a lot of respect, actually. You know, the way we label people these days is as if you went to a cardiologist and you said, "Oh, the cardiologist says, oh, you have a chest pain disorder syndrome." And that's about the sophistication that our DSM gives us. So to start off, we don't really learn to really figure out what is going on with this person and what do they need. And so the whole system having these fake labels on people, that's crazy. And then we get a number of prescriptions that are crazy. And then we get some evidence-based treatments that don't work for most people. And so I'm
Right.
actually astounded by how placid therapists are about being dictated foolishness by the powers that are.
Well, I think most therapists don't feel they have a choice.
Yeah, see, and maybe that's an issue.
Right. I mean, if if being able to serve your client requires that they use their insurance, and the insurance requires you use a diagnostic code, uh, and that you um, and um, and that you endorse whatever crazy mixture of symptoms the DSM has told you are associated with that code. I mean, the nice thing about trauma is that it's almost always appropriate to give a depression or anxiety disorder.
Sure, it is, but it's sort of, yes, it is, and it accommodates certain realities,
Yeah,
but it doesn't really
it doesn't it
feel
doesn't serve treatment.
about your work, does it? Yeah,
Yeah. And there are many countries where diagnoses are only given by psychiatrists. And I teach therapists because they get the client with the psychiatrist diagnosis.
right,
And say, you know, you can just tell your client your diagnosis was made for the purposes of psychiatry, for the purposes of prescribing medication. In your therapy, we're going to work with your trauma because
right,
that's really
right.
the issue that you're here for.
Yeah, so that's the contrast between wisdom and accuracy.
Right.
Yeah,
Right. But notice
very fast response,
I
but
was very
more
proud of myself
accurate.
because I managed to find a way not to
Right,
sound critical of the psychiatrist
right.
while at the same time saying, let's ignore that diagnosis.
But see, I think we have a more important job, and is to help people to really figure out. And I think you do that marvelous in your own way. What is really the matter with this person, and what are the issues that we need to really focus on.
Right. And
And
what
and it,
matter of that individual
yeah,
is not the memories,
yeah,
it's the consequences, it's the effect.
right. And so there's a core issue in the what people still get taught in schools is the issue is that event. And we should talk about the event. And I see this all the time.
I
Uh,
do
with
too.
people, let's talk about a trauma story. And that's it, not really the trauma story. It's good if you can tell that story at some point in your life, but you start off with all the changes that trauma brought about in who you are right now.
Right.
That you cannot regulate yourself, and you cannot focus. You become freaked out and anxious and upset, and you cannot commit yourself emotionally to anybody. All those things are the urgent issues, and that old story has something to do with it. And sometimes it may be helpful to say, oh, that happened to me. Oh, no wonder I messed up. But that doesn't really solve you from being messed up. Now you know why you're messed up, which is not a
But
bad way of starting.
right, right, right. And, I have a very, 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 very long-term client who I call Annie. And one of the beautiful things that's happened, because her trauma history was so extreme, like over 100 perpetrators, et cetera. And so I always knew we were not going to touch that trauma story with a 10-foot pole. And so we just kept doing sensory motor work,
Yeah,
my trauma-informed parts approach,
yeah,
trauma-informed stabilization
yeah,
treatment.
yeah.
And now, as she's really in phase 3 and finishing up her work, she is linking the trauma story. Like like now she can remember, she doesn't want to remember the details, but she can remember what happened. She can remember how extreme it was, um, without becoming dysregulated.
And then the big issue, which I bet you have helped her with, is that she has compassion for herself, what happened to her.
Right. She has
And that-
compassion
and
for
that's
her
one of the
part.
hardest things. Huh? That the hardest thing is people keep hating themselves for how they didn't resist, they didn't fight back, they didn't assert themselves back then when they were 2 years old, like when they had no way of doing that, and they keep hating themselves for not having protected themselves more. And so it's a very, very core issue is how do you get to really have compassion for this wounded creature that lives inside of you? That's really such a critical, critical piece. Huh? Yeah,
Well, that's why I love my parts approach,
yeah,
because
yeah,
it's really based around being curious and compassionate
yeah,
toward the parts,
right,
and their woundedness.
right.
And and when you can mindfully notice a part that's wounded, you don't relive the wound. You
Yeah.
you notice the wound and how the part is suffering, and
Right.
it's easy to have compassion for that part. And this is what's happening
Well,
to
let me say easy. Now,
no, it's
I
easier.
have long-term patients, and like some of us have really very long-term people in our lives who actually have done very well, but that core issue of I'm basically damaged, there's something fundamentally wrong with me, is still a challenge for many of them.
Yeah,
Yeah, yeah,
yes.
yeah.
But it does help when that that self-hatred and self-blame is understood as a part
That's right. That's right.
of the part that keeps blaming
Yeah.
herself.
And the reality is, and you may remember Anne Burgess, who
Uh-huh.
preceded us, who first talked about the rape trauma syndrome when she was a nurse at Boston's City Hospital. and, uh, and Burgess, before we invented PTSD, talked about how the rape victims who blamed themselves they're better than victims who don't blame themselves. Because if
Oh,
you blame yourself, you can say, next time I'm going to do something differently. And
right,
so blame is a useful thing because it gives you the feeling I am in control.
right.
So
Absolutely. Yes.
complicated, huh?
Yeah. 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 And I often work
Yeah,
with the self-blame
yeah,
as a relationship between the part that blames
yeah,
the client for what happened and the part who feels the self-hatred and the self-blame.
yeah,
Yeah, and absolutely. When when my clients ask the blaming part, um, what are you worried about if you don't blame me? The blaming part always says, well, then it can happen again.
yeah.
Exactly
That's
as
right.
you said.
That's right.
Exactly as you
Yeah,
said.
yeah,
All about control.
yeah, yeah. And again, as you're talking, I also want to say what a marvelous work it has been for both of us, huh?
Oh,
To discover these things. I feel so privileged to have delved so deeply into things and having companions and colleagues like you
yeah,
who together helped us to sort of open these things up and how rich it is. Huh? Like it's really
right.
very and so when you see these simplistic formulas, you go like, oh, I feel sorry that your world is so simplistic because it really is infinitely complex for dealing with.
Yeah.
Yeah,
Right, right. No, I think you're so right. I mean, there is something so deeply satisfying about trauma work. And people always say, "Oh, trauma work, that sounds terrible." I say, "No, actually, it's the best work in the world, and it doesn't depress you. It actually gives you hope for humanity."
yeah. It gets you in touch with the life force. Huh? And
Yeah.
so the stories are unbelievable stories. And I still, after all these years, hear myself say sometimes to people who come to see me, that's unbelievable. And they
Mm,
say, you don't believe me? I said, no, it is unbelievable that people do things like that to a person. But,
right.
uh, but so the stories don't become less agonizing.
No,
What is great for us to see is that life force. Huh?
right.
But basically, anybody who comes to my office go like, and you are still here and still want to go on with your life. You still have hope. That's so amazing, you know. Yeah, yeah,
Right. And look, I think my favorite question is,
yeah,
how did you survive?
yeah, yeah,
Because because that that tells them so much about themselves,
yeah,
right? Because when you just think about what was done to you,
yeah,
you feel shame, you feel self-blame.
yeah,
Um, but when you start thinking about how you actually survived
yeah,
as a child, as a teenager,
yeah.
it's
That's where both the sensory motor psychotherapy, which we both learned, and the psychodrama comes in creating new scenarios. Back
right.
then, I couldn't, but if I were there right now, I would kick the shit out of this person.
Right.
If I, if I, knowing what I don't know, I would have run away, you know. But back then I couldn't. Huh? And so,
Right.
a very central thing for me is Dick Schwartz's notion of unblending. Huh?
Right. Oh, me too.
That is such a core issue of no,
Yeah.
you are not a 2-year-old who's getting molested right now. And you're, in fact, you're 53 years old. And today, how are you dealing with things today? Huh? As opposed to back then when you were just a little kid. Yep. Yeah.
Right.
Yeah.
Right.
Yeah.
Right.
Yeah.
And that's why I love parts work because it's easy to talk about the child. It's really interesting because most of the clients I've seen over these 44 years, um, are hurting more, suffering more because of the abandonment rather than the molestation.
That is, I mean, that is, again, something you and I have very much in common is that the issue is no longer what happened to you, the title of that wonderful book by Bruce Perry and Oprah, but even more, and who was there for you?
Right.
And you and I have both discovered that people can go through horrendous things as long as they feel loved and cared for.
Absolutely.
Yeah.
Absolutely. Right. It's essential.
But
And
it's also a harder thing to treat. We're,
oh,
we-
yeah.
we're pretty good, like with EMDR, to deal with the trauma memories,
Right.
but the issue of there's nobody there for me, and must be basically a despicable person that nobody intervened for me and nobody protected me, is a much harder thing actually to repair.
Right. Oh, absolutely.
Uh,
Or I'm so inherently unlovable
yeah, yeah,
that people chose to hurt me and then leave me.
yeah. And you had every reason to. Yeah, yeah, yeah,
Yeah. Yeah.
yeah,
Yeah. That's why my my approach TIST um is focused not so much on unburdening as in IFS,
yeah,
but on really sort of memory reconsolidation work with parts.
yeah, yeah,
So so that the parts have a a
yeah,
somatic and emotional
yeah,
experience
yeah,
of being held in mind, not being abandoned,
yeah.
being valued, validated, believed, cared for.
Yeah, I'm very much with you on that. Actually, I've said to my good friend Dick Schwartz from time to time, you know, IFS is not really, to my mind, a trauma therapy. It's really more an attachment therapy. And Dick sort of always dismisses that. but
Right.
but it is really amazing how quickly you and I, once we got exposed to parts work, we embraced it. We didn't hesitate for a moment, like, yeah,
Right.
important. Like that's really,
Right.
yeah,
And
yeah,
because IFS was the parts approach that was available to us in the 90s and the early 2000s, um, it was adopted by lots of trauma therapists. That doesn't make it a trauma-informed method.
yeah. But I don't want to say anything bad about IFS.
No, no, no.
I've
I
been
mean,
actually on the receiving end of that also, found it very helpful. Um, and I use it with my patients all the time. It's fundamentally a very good part of the work that we do. Yeah, yeah,
absolutely.
yeah,
I mean, it's certainly, I mean, I self-taught. I taught myself IFS from Dick's book, The Mosaic Mind, in 1996. And it was really a gift.
yeah,
Um, it transformed how I was working with people. And and TIST is very, very influenced by IFS. Um, like the concept of unblending, which I think is genius.
yeah, yeah.
Yeah.
And
Yeah.
not easy. But upblending is not an easy thing, also.
Oh, oh my God. No, it's not. It's not. Yes. I mean, it's all, it all comes together because what you're making me think is that this this repetition that it takes to help people learn to unblend from their parts. Um, I I get that repetition
Yeah,
from sensory motor psychotherapy.
yeah,
Because in sensory motor psychotherapy, you know, it's very repetitious and it's rhythmic, right? Which is also, as you write about, very, very, very helpful. And and so and this idea that it took many, many repetitions for the trauma-related patterns to develop. Of course, it'll take many, many, many repetitions um, to develop a new pattern.
Yeah.
Yeah,
And there may be ways of speeding it up. Uh,
yeah,
I think in my work, psychedelics really can speed things up tremendously. I think sensory motor work, somatic experiencing can speed up things tremendously also. So there are certain things that we have learned that we didn't know before and that
right,
all of us know. But another thing that I like to tell people is that, no, what I write about in the book, Body Keeps Score, happens to be what I happen to come across in my lifetime, in my cultural parameters that I've lived in. But that is not the full spectrum of what can be done. It
right.
happens to be the little pieces that in my life I've been able to accumulate, and you have many of the same things. But there's other things that we don't know that people are doing that may also be very good. Yeah, yeah,
Right. Oh, and we once had this idea that there could be a single unitary one treatment that would magically resolve trauma. And so what we've learned is we have a lot of wonderful treatments, and all of them contribute something.
yeah, yeah.
Nothing contributes everything.
But and so it's you and I are good examples of lifelong learners. Like you and I really had to do a whole webcast on what we have learned in the last 2 years in our lives.
Right.
Not puppies anymore. Like,
That's for sure. Right. Right. But that's good. I mean, I feel like that's a gift. And, and it's a gift that there's more to learn.
yeah. Oh,
And we
absolutely.
just don't know what it is yet.
And like in the last month, I've been exploring music and rhythmicities, which we haven't really paid much attention to at this point.
Right.
It's going to be what we'll be working on. There's so many different things that can make a difference in people's
Right.
lives.
Yes. Yeah. 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 If we can just kind of get away from what I call the silo approach, where every method is in its own silo competing with all the other methods, uh, then it's, you know, then people can use the wisdom of all the methods, depending on the particular person they're treating.
Let me take an, an expanded approach. So we have friends and colleagues who have invented fantastic things, uh,
Right?
who are more or less stuck in that particular approach. And
Right.
there is a lot of room in the world for people like that also.
Absolutely.
We explore one approach very deeply. Huh? And so I'm glad there's some people who just do IFS or just do sensory motor therapy because they need to teach that method to people.
Right.
I mean, it's the end of the story, but boy,
Mhm.
I'd like to honor them also for the intensive work that they've done to,
Oh,
to bring that to fruition also.
absolutely. And I know, for Dick and for Pat Ogden, uh, this was decades of work
Hmm.
to get treatments they'd already developed actually recognized.
Yeah. And so they're all part of this whole
Right.
mosaic. Yeah.
Yeah. Yeah. I mean, the one message I still feel that I have to keep getting across to younger therapists is don't think that the event memories are the answer.
Yeah. Yeah.
Right? Don't think that talking about it is the answer because it's striking that idea has held on and held on despite all the evidence to the contrary.
Well, part of it is our diagnostic system, which defined PTSD as a horrible event that overwhelms people's capacity. And that is crazy because very few people have one event.
Right, right.
And uh, and indeed, if people have one event, you can really focus on that one event and
Oh,
do amazingly helpful therapy with, we have the research for EMDR. I imagine brain spotting and other things may work almost as well, but the research isn't there. Yeah.
right, right. But I have met in 44 years of practice, I have met a grand total of one person who had a single incident trauma in childhood.
I had I've had a few more than that, but my percentage is less than 1% of my total.
Right, 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 right. Yes, exactly. And the other thing I'm sort of really focused on these days is is this really obvious notion, it's just that we don't use the language, that traumatic events take place in traumatic environments. So our clients are dealing with the the ramifications of the whole environment, not just, every Tuesday they were abused, all the other days they were unsafe, threatened, scared, ashamed.
Yeah, yeah, yeah. Yeah, the context is, of course, terribly important. And of course, there's a historical background from that. Huh? Because when I was a puppy,
Yes,
um,
ancient days ago.
60s and 70s, so that's well before most people who listen to this are born, uh, the field was entirely into parent blaming.
Right,
You had the refrigerator mothers causing autism,
right.
Tylenol causing autism, and it was horrible. And parents were blamed for making the schizophrenic mothers, stuff like that.
I
And
remember.
some senators had psychotic children. And they said, we don't want to be blamed for what happened to our kids anymore because this is crazy and it doesn't help anybody. And they specifically instructed NIH that they could not do the sort of environmental overview, which I was totally in favor of.
Right,
But then, on the other hand, if something goes wrong with your kid, because we don't want to get into parent blaming, but then if something goes wrong with your own kids, the first thing we do think about and should think about is where did I go wrong
right,
and what could I have done better with my kid that my kid wouldn't be so upset. So we are we should really investigate what our contribution is to our all intimates becoming ill. But that doesn't mean that you blame these people. Uh,
right.
As I was raising my kids, I did many things wrong. And luckily, I had a few friends who, from time to time, said, "Hey, I saw what you did with your kid, and that was really cool." And really nice that somebody pointed out that I was doing some things that really were harmful to my kids. Uh, but parent blaming doesn't help anybody.
Right.
Saying that
Right.
an
Ah,
environment that really damaged this kid is reasonable because maybe we can do something about it.
right. Right.
But so
Right.
it's a very complex issue that, uh, and what we see, interestingly enough, in our work is that people start with of their self-blame, and when they stop with their self-blame, they start having compassion for their parents.
Right.
Oh, and I feel so bad that my father never got to see what a wonderful kid he had, me. And he never got the joy that the parent deserves having for having a
Right.
wonderful kid like me.
Right. Right.
So the compassion spreads from people inward, outward. Huh?
Oh,
Yeah,
that,
yeah.
you know, we have to end, and I can't, but that's a beautiful ending. Right. 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 It's like, right. That spreading of compassion.
Okay,
I could talk to you for a week.
we do, and we do. So,
So take care. Sorry we have to meet like this, but it's a wonderful thing to be able to do.
okay, bye, Janina. Okay.
Okay, bye.